Good morning. My name is Joshua Lyons, and I want to thank the SAGES Committee for giving me the opportunity to discuss our data. Our presentation today is entitled Fundoplication at the time of paraesophageal hernia repair does not decrease the rate of hernia recurrence or postoperative reflux. These are our relevant disclosures. So since the mid-1950s, fundoplication at the time of paraesophageal hernia repair has been routinely performed with the goal of reducing both postoperative recurrences and the development of postoperative GERD. However, the current SAGES hiatal hernia management guideline states that there is no high-level evidence to support this practice of routine fundoplication, with previous studies having conflicting outcomes. Therefore, our study was designed to again evaluate the need for fundoplication at the time of paraesophageal hernia repair by comparing various postoperative outcomes. A little bit of history first. When the management of paraesophageal hernias was first being developed and refined, there were two schools of thought that emerged in the late 1950s. The first was led by some great names like Rudolf Nissen and eventually de Meester, which focused on this proposed, but back then not yet proven, flap of tissue, which we now know as the LES, that required some reinforcement of some sort. This was initially attempted in multiple ways, with the gastroplication, which we now call a fundoplication, emerging as the preferred approach. The second school of thought, led by Philip Allison, considered paraesophageal hernias to be related to a failure of the diaphragm, and that quality closure of the crura and restoring that normal anatomy should be the focus. For reasons that we don't have time to go into this morning, fundoplications at the time of paraesophageal hernia repair quickly became almost dogma, however, again, without high-level randomized controlled trials to support this. So our study was a retrospective review of all patients who underwent a paraesophageal hernia repair over a 14-year period from 2010 to 2023. Patients were divided into two cohorts, those with and those without a fundoplication. Of note, we did exclude patients who underwent a concomitant procedure, mainly bariatric procedures. Postoperative outcome measures were then obtained from the medical record, including hernia recurrence, which was defined as a recurrent hernia being seen radiographically or endoscopically at any point postoperatively, reoperation for recurrent symptoms or hernia recurrence, persistent GERD greater than 30 days postoperatively, and persistent dysphagia, again, greater than 30 days postoperatively. Some basic demographics were similar. Of note, patients that underwent a fundoplication were slightly older and had higher rates of cardiovascular disease. However, on multivariate analysis, no demographic variable was predictive of the postoperative outcomes that were studied. So these were our main results. Patients who underwent a fundoplication along with their paraesophageal hernia repair, and our study actually had higher rates of documented hernia recurrences, 19% compared to 12%. But there were no differences in reoperation rates at about 6 to 7%. As some studies have shown previously, persistent dysphagia rates were also higher in patients with a fundoplication at 12% compared to 7%. And finally, GERD rates were very similar between the groups, with exactly 7% of patients in both groups developing persistent postoperative GERD. In review, these data do not support the use of routine fundoplication at the time of paraesophageal hernia repair. In fact, patients with a fundoplication actually had higher documented rates of hernia recurrence. And documented hernia recurrence is the key, as we hypothesize that patients who recur without a fundoplication may be asymptomatic or minimally symptomatic and controlled medically, thus not undergoing any further diagnostic testing. However, in patients with a fundoplication, a recurrence likely has a higher chance of becoming increasingly symptomatic and therefore requiring further diagnostic testing and discovery of the recurrent hernia. It is the practice of surgeons who do not routinely perform fundoplications at our institution to perform an intraoperative EGD after the hiatal closure, and if a Hill grade 1 valve is seen, thus signaling restoration of that normal anatomy, no fundoplication is performed. Aligning with Philip Allison's initial description of hiatal hernia repairs and focus on the hiatal closure itself, if paraesophageal hernias are considered a disease of the diaphragm, then at the time of repair, full hernia sac reduction, followed by adequate esophageal dissection to ensure sufficient atrium-abdominal esophageal length, and then meticulous closure of the crura, again, thus restoring normal anatomy, certainly are the necessary steps. And then finally, further manipulation of the widely dynamic and complex nature of this anatomic region with a fundoplication is potentially not needed. Thank you. I'd be happy to take any questions.